Hello everyone, my name is Mars Fiogios, and in today's vlog we're going to speak about the treatment, the interventional treatment of a ethmoidal arteriovenous fistula. The special in today's case is that we use the transvenous arm approach for the treatment. You know that we started using the transradial approach for neurointerventions in the last few years, and it has a lot of advantages compared to a transfemoral approach. In this case we combined the transradial approach for the arterial axis together with the transvenous approach for the transvenous axis. So we were able to treat this patient only by puncturing the arm. Of course this has advantages as we have discussed in the past compared to the transfemoral approach. So let's start with the case, and we can discuss the images as we go along. Okay, so if we stop our video in this first frame, you can see our setting in the angio, where we use a radial first approach for the arterial side with a 4 French radial sheet and a 4 French diagnostic catheter. This is a symptom catheter that I placed in the carotid to be able to control the fistula. And you also see the cubital first approach for the venous side, where we placed an 8 French normal femoral sheet in the antecubital vein, and then with a 6 French long sheet I was able to navigate towards the internal jugular vein and then the superior sagittal sinus. So as we continue in the video, you can see the navigation towards the carotid here with the SIM2 diagnostic catheter, and then also the navigation towards the right jugular vein. And I find this image is interesting because as I was planning this case, I wasn't so sure if I would be able to go easily to the internal jugular vein from the arm. But you know, after doing more neurointerventions from the arm using the transvenous approach, I find this even easier than coming from the femoral side. Then we can see the first angiograms, and again you can see here nicely the ethmoidal fistula, AV fistula, and the drainage in the cortical vein. So again, that's a high-grade fistula that has a bleeding risk, and that's why we treated it. And we placed the guide catheter in the proximal part of the superior sagittal sinus. Then with a 5 French distal axis catheter, which in this case was a Catalyst 5, we were able to reach the rostral side of the superior sagittal sinus, and then we used a balloon catheter, so a double lumen balloon catheter, which in this case was a Scepter, to go all the way towards the draining vein, and then retrogradely inject our embolic agent towards the fistula. So if we continue with the video, you can actually see here nicely annotated the arterial feeders, the target vein, and then you can see the injection of the embolic agent. So this is here seen nicely how we can retrogradely inject the low viscosity fill in this case. Of course, we load the blood pressure during the procedure, and after inflating the Scepter, we started injecting the embolic agent through the Scepter balloon. Again, that's a double lumen balloon, so you can do that. You can inject in the inner lumen while inflating the balloon and having your pressure cooker augmented method. We can see here the native image of this procedure. So again, you can see here that's the tip of the Catalyst 5. Then you can see the balloon, which is inflated in this case, so it blocks the reflux of the embolic agent, and then we can push the embolic agent towards the fistula, although we are like 1.5 centimeters away from the fistula's point. But again, that's the beauty of the pressure cooker method. You can actually push your embolic agent towards the fistula, and then as you can see here, the before-after images, you can see the complete occlusion of the fistula. Also from the lateral side, you can see we don't have any contrast in the fistula anymore after embolization, and this is a 3 months follow-up with MR angiography, where you can see that it's completely treated. We don't have any residual fistulous vessels, And also in this case, we had some edema directly after treatment in the right frontal lobe, but in the 3 months follow-up, the images were without any edema, without any bleedings, and also the patient didn't show any symptoms after treatment. Okay, so there are a couple of questions regarding this case. The first would be, why not go straight forward and use a transarterial approach to treat the fistula? And in my opinion, the transvenous approach is safer because you don't put microcatheters in the ophthalmic artery, so you don't have the possibility of a dissection of the artery or of an embolus in the retinal arteries from the venous side. And also regarding the questions, why not perform open surgery? We discussed this with our colleagues, and we think for a younger patient who didn't really want open surgery at the moment, it is a good and safe alternative to try and treat this lesion from the transvenous side. Regarding the pressure cooker method with a balloon, I really like it because it's a straightforward approach where you have one catheter, the balloon catheter that you use. So I usually use the Scepter or Scepter Mini for these cases. Of course, you could also use a normal pressure cooker method. Place the flow-guided catheter, microcatheter just before the fistula from the venous side, and then do a plug with flow coils and with glue in the detachment area of the first catheter. Again, that's a bit more complicated, and you need 2 microcatheters, so you have also more costs. That's why I really like in this case, to use a balloon augmented pressure cooker method. So thank you very much for watching, and please subscribe to our channel to see all the latest news and comments on our new interventions. Bye!